Hello, I'm Michelle Levander, Director of the USC Center for Health Journalism. Thanks for joining us and welcome to our Health Matters webinar, covering coronavirus, the long COVID nightmare. Today, we're going to be talking about long COVID, a persistent, baffling, and debilitating set of symptoms that is besetting a growing group of Americans. For many, it seems, the pandemic will never end. Patients report persistent after effects, from extreme fatigue, heart problems, and shortness of breath, to brain fog, depression, and even psychotic episodes. The suffering isn't limited to the most severe cases of COVID-19 either. With more than 30 million confirmed COVID-19 cases in the US, there is growing urgency for researchers and doctors to unravel the causes and potential new treatments. Today, we'll talk about what we've learned since long COVID first grabbed headlines last year, as well as how to tell informed and compelling stories about a medical condition that continues to upend lives and that could impact the recovery of nearly every community across the country. Here to help us explore this urgent topic and provide ideas for reporting, we have two distinguished speakers. Pam Belluck is a health and science writer for the New York Times, where she's been writing regularly of late about long COVID. In 2015, she was one of 7-time staff writers awarded the Pulitzer Prize for coverage of the Ebola epidemic, as well as other top journalism honors. We'll also hear from David Putrino, who's the Director of Rehabilitation Innovation for the Mount Sinai Health System in New York City, where he oversees its Center for Post-COVID Care. A physical therapist with a PhD in neuroscience, he has cared extensively for long COVID patients since the pandemic began. Previously, he worked as a clinician in Australia before moving to the United States to study computational neuroscience at Harvard Medical School, MIT, and NYU. Dr. Putrino is also the chief mad scientist of Not Impossible Labs, a group that crowdsources technological solutions for high-impact humanitarian problems. We want to thank the Commonwealth Fund, the National Institute for Healthcare Management Foundation, and the California Endowment for supporting this program. We also want to express our appreciation for donations to support this work from individual participants like you. You can tweet about the webinar at the hashtag LongCovid. A word about our format today. We'll be hearing first from our panelists, and then we'll turn it over to audience questions. Because we have many people participating in this webinar, we'll ask you to write your questions in the Q&A panel of Zoom. You can write us there too if you're experiencing any technical problems. We will be archiving this webinar later today at centerforhealthjournalism.org. Now let's get started. Earlier in the pandemic, we first began to hear about people called long haulers who suffered lingering symptoms of COVID. These days, new studies are emerging that are starting to tell us much more about how prevalent these conditions might become. Dr. Putrino and Pam, what are we learning about what's been called long COVID? What are your patients experiencing, Dr. Putrino? And Pam, what are you learning from neuroreporting and how it is affecting people and interfering with their daily lives?
Want to start, Dr. Putrino?
Sure.
I don't have the title of chief mad scientist, which I think I did. So,
fair enough.
I think I have to defer to you.
So I mean, this is a very long form question, I guess. We first started seeing long COVID emerging in our cohort of patients that we were managing around late April, early May of 2020. It presented to us as we were managing a large group of people with acute COVID symptoms who we were managing with telehealth to keep them out of the hospital, because at the time, beds were very hard to come by. And as we were managing this group of cases, around 10% of these individuals just weren't getting better. They were having persistent symptoms such as shortness of breath and headaches and chest pain. And then they were developing new symptoms like extreme fatigue, exercise intolerance, cognitive issues, difficulties such as short-term memory loss, difficulty concentrating, issues finding the right words, problems with executive function and emotional control. And this was where we started to suspect that what we were seeing was a post-viral syndrome, which is, as we're all learning now, is something that is quite common through history with viral outbreaks. They're typically followed by a number of individuals who have a post-viral syndrome that they find it difficult to shake persistent symptoms. And as we've worked on cataloging these symptoms, which are very diverse, highly debilitating, and affect the entire body, we're now tracking around 60 or more symptoms, distinct individual symptoms, and we're starting to slowly get a handle on best practices for managing what could be one syndrome or could be many different syndromes, and we're starting to try and unpick all of those mysteries.
Thank you. And Pam, what can you share about what you're seeing and you're reporting about all this?
Yeah, I mean, I would echo, all of what Dr. Putrino said, and, just kind of underscore that the complexity of this condition or conditions. I am hearing from, it's very rare to talk to someone who only has one symptom. Very often it's multiple symptoms that sort of interact with each other. And I think that's something that we're also starting to learn about. What is the interplay of, say, a cognitive deficit that you might be experiencing? How does that affect your physical symptoms? How does that connect to your rapid heartbeat, for example? Or is that making it harder for your shortness of breath to, resolve? There's a lot, I think, that we're learning about, or we need to learn about the interplay of those things. I've seen a few studies and talked to some patients recently who seem to suggest that like symptoms can come in clusters. Some things go together. There's a sort of waxing and waning, and kind of like people get over one set of symptoms and then they think they're okay, and then a couple months later something else starts to happen. So it's very complex. I think the understanding of the causes is still very, very fledgling, and there may end up being multiple causes and multiple pathways, and it's really fascinating as a reporter to learn about these things. It's also kind of flashing yellow caution lights at every point to make sure that you're not jumping to conclusions, and that you're trying to get the best sourcing and the best scientific understanding that you can.
Yeah, and what do we know and not know about the prevalence of this condition in the broader population?
We know a lot less than we know. We know a lot less than we think we do. I mean, the numbers that have been reported, depending on where you read, will be anywhere from 10% to 35% of people who had an acute COVID infection will go on to get symptoms consistent with long COVID. I think, right now there's so much nomenclature out there. So Dr. Fauci recently spoke about PASC, post-acute sequelae of COVID. And one of the things that I think is important is that we probably, we dig into what do all these classifications mean. So post-acute sequelae of COVID is basically anyone who's having a symptom after their initial acute COVID infection falls into this big overarching umbrella. Now from there, and to be clear, like if you read the literature, up to 70 to 80% of individuals who are hospitalized with COVID will end up with one or more persistent symptoms. So as we start to try and break these people into different groups, what I've been doing with in collaboration with Dr. Zhijian Chen, who's the director of the Center for Post-COVID Care at Mount Sinai, and has just been phenomenal. I feel really bad for him because he's just like never stops working, but he's been phenomenal throughout all of this. Is we basically have this chart where if someone shows up to the Center for Post-COVID Care and they have persistent symptoms where Dr. Chen can look at a blood test or look at a scan and see a proximate cause for those symptoms. You know what? You've got shortness of breath and I'm seeing extensive lung damage. We're sending you to pulmonary rehab. You're having chest pain and I can see heart damage, off to cardiac rehab. Your sort of electrolytes look out of balance. Oh, you've got kidney damage, off to a nephrologist. So for all of those individuals who have a very clear medical cause for their persistent symptoms, Dr. Chen's managing them, and they're all in the sort of big umbrella of post-acute sequelae of COVID. For all of the individuals who have medically unexplained physical symptoms, so we look at their scans and we look at everything and we say, I can't really understand why you're having these symptoms according to the tests. Everything's within normal limits. These are the people we typically classify as long COVID, or what we're calling is post-acute COVID syndrome. I'm the lucky person that gets to handle all of those. They get sent to my rehab group, which is an interdisciplinary team with a lot of experience in treating, managing, and rehabilitating autonomic nervous system conditions. And we have started to mount a rehabilitation approach for these patients.
And I think just to add, I think to hit a couple of things Dr. Putrino said, there are a number of these post-COVID clinics that are springing up around the country. I think the best ones, like his, are finding that this interdisciplinary approach is really important because, again, the complexity of it, you need to have somebody who who knows about neurological issues. You need to have somebody who knows about how much physical therapy can do, all that stuff. The other thing is that, the lack of evidence of damage on, say, an MRI of your brain, or, a lot of other scans that people with long COVID are finding, just coming up negative. That's important it's important in many ways. One, it's important because it so far has, stymied our ability to find like an actual, okay, this is damage, we can fix it this way. But it also means that for a lot of people, their symptoms are being sort of dismissed, or kind of, if they're going to a general practitioner, may just say, I don't really know what to do. Doesn't appear to be anything particularly wrong with you. And some people are being told that it's, psychosomatic and that kind of thing. So I think we're at a moment where, fortunately, the NIH and others are starting to elevate the profile of this and have a name for it, as cumbersome as the name is, and are starting to put together kind of a list of symptoms and a definition of it. But there are a lot of people who are kind of floating in this purgatory right now, and if they're lucky enough to find a post-COVID clinic where they're taken seriously and people say, oh yes, this is something real, that's great. But a lot of people aren't lucky enough to at this point.
And Pam, you have written, as I hear about all these resources that are being marshaled in Dr. Putrino's clinic, and the kind of really medical mystery sorts of things that we're experiencing, many people aren't finding their way to places like that. Those are still small, very elite centers of excellence. And you've written about how many people who are experiencing long COVID in these initial patient groups are white and middle class, and that there's a whole other universe of people we don't know about. Can you talk a little bit about that, both of you, and the implications of this for people who are maybe experiencing skepticism from their employer but have no way to document any of this?
Yeah, I mean, I think what the reports that we're seeing right now are basically, as I keep telling my editors, this is sort of the leading edge of the people with long COVID who are being, who are presenting at clinics. And there are more and more of them springing up. I would say they're not just at elite centers, but I don't know, how, I don't know how many, I don't know how high level they are, but definitely I just heard about one in Appalachia that's opening. So that's another good sign that I think, around the country, not just in sort of the major cities, your people are presenting and doctors are trying to figure out what to do. And there are these post-COVID efforts happening, and that's all really good. But right now, the early people who presented to these clinics were the people who had a lot of determination and resources, and often private insurance, to be able to, go to the doctor, get slapped down because their tests were negative, not slapped down literally, but, just get sort of like this, sense of, we don't really know what to do with you, and keep trying, and then keep looking until they found out, oh, there's this thing called a post-COVID clinic, and, making the time and effort to go. And that's, just by definition, a fairly limited group of people. So a lot of those people so far, a lot of the patient populations are, are white and relatively well resourced, and maybe have the time to take off from their jobs and all of that stuff. And I think, as we know so well, this pandemic has had outsized impact on, communities of color and urban communities and essential workers. And it's not that they're not experiencing or going to experience these symptoms. It's just that our medical system hasn't been able to reach them yet. They haven't been able to have access to the medical system yet in the way that they are, I think, clearly going to need. And I think, would you agree with that, Dr. Putrino?
No, totally. I mean, I would agree to that, and I would say that it's been this horribly fascinating thing to watch. We learn about health disparities. We try to be aware of health disparities. We try to be anti-racist, anti-ableist, all of these anti-ists in everything that we do. And it certainly, I have been watching a health disparity emerge in front of my eyes, and that's been distressing and frustrating. For those of you who want to, sip some tea, if you take a look at my Twitter account, actually, which is at Putrino Lab, we're in the middle of having a fight with a journal right now because they, a scientific journal, PLOS One, sat on one of our earliest papers that was reporting post-acute COVID syndrome, reporting the symptoms, and we insisted on including in our sample, even though we separated the samples out, we included in our samples those who were PCR negative and antibody negative. And we said, this is an important part of the story. We cannot discount the fact that people who are PCR negative and antibody negative can still have had COVID in their history and are now having post-acute symptoms. The journal refused, we had like 2 holdout reviewers that just wouldn't publish it with this in. And so we withdrew the paper and said, you know what, we're not publishing it. Through the course of the review, one of the reviewers actually said, this whole PCR antibody thing, it's not even relevant. The United States is a wealthy nation. If you want a test, you can get a test. And that is the level of tone deafness. That is the level of bias, that we're dealing with. That person is not a bad person. That person is just a very uninformed person who doesn't understand the level of health disparity that occurs in, with the wealth disparity and with, and with just poor health disparities across historically excluded groups, and as we were discussing previously, Pam, it doesn't surprise me at all from just a pragmatic point of view that it's only white women who are getting this condition, because I'm fairly certain that any Black woman who walks into a hospital system who's used to being discriminated against is going to get extra discriminated against in this particular case, because that's how the system is. And you see this insidious method of how it works by the journal's not letting us publish on the cases that are most likely to be minorities, most likely to be people of color, most likely to be people who are living in low socioeconomic status communities. And that is how you create a health disparity.
Thank you, Dr. Putrino. And you mentioned in talking about some of the challenges here, this idea of whether somebody has a positive COVID test. And as we know, earlier, talking about sort of accumulated disadvantage, there was a lot of lack of resources for testing in more low-income communities and communities of color. So somebody who never had that test and now is experiencing symptoms of long COVID, are they going to be at a double disadvantage?
That's, well, unless we really get the word out that they should not be. You know, the World Health Organization created criteria that allow you to diagnose these things based on symptom presentation, as opposed to PCR status or antibody status, because the state of the science is that antibodies fade and PCR tests come back false negative all the time. We had cases of people showing up acutely ill, testing negative on PCR, and then showing up 2 days later being intubated. And then interestingly, you know, in the early phases, these people definitely had COVID. They got intubated, they got treated, and then their insurers were like, oh no, it wasn't COVID. Look, there's a negative PCR test in your history. And we had to say, are you kidding me? Like, this person had COVID pneumonia, and we just discharged them after them being on a ventilator for 3 days. These were things that happened, but we really want to be able to pin our diagnosis on a test. And that, in a nutshell, is the crisis we're facing right now. Is no one's willing to be symptom-centric and patient-centric and just working with patients as partners, listening to the voice of the patient and the community and saying, how can we help? We just want a test, we want a clinical pathway, and we want a medicine that we can prescribe and then just forget about it. And it's not going to work that way. And
given all this ambiguity that we're seeing, and where, you know, there's not even an agreement between, say, a clinician and an insurer, Pam, how do you navigate that as a reporter? You're supposed to be doing fact checking. You're supposed to figure out if somebody, you know, does have long COVID or has some other condition if you're writing about it. What are some of the steps that you're taking?
Yeah, I mean, well, I think, you know, generally I try to do what I always do, which is, you know, if I'm talking to patients, and I do a lot of stories where I'm talking in depth to patients. I, you know, especially if I'm, you know, they're more than a sentence or something in the story, if I'm really writing about their experience, I want to talk to the doctor who's caring for them. I want to see their medical records. And, you know, then, you know, it's partly just trying to figure out, okay, you know, is there, not that I'm not, you know, evaluating them as a doctor, but I'm listening to what they're saying and I'm asking them questions like, is this something that is really new for you? Or did you have something like this before? You know, talking to the doctor, could there be any other kind of explanation? Are you pretty convinced that this is, you know, what would fall under the rubric of long COVID? So it's sort of trying to, you know, get a lot of different cross checks and just kind of get a sense for myself of, you know, yes, this is actually an example of whatever it is that I'm writing about, whether it's brain fog or, you know, somebody who was hospitalized multiple times after their COVID, that kind of thing. And so, you know, there is some, I think, you know, in all of these stories, what I try to do, and this is just a maxim that I followed prior to COVID as well, is just, you know, try to be clear on what the medical establishment science doesn't know yet. What are the unknowns in this area? And, you know, as well as what they think they know and what their theories are. And I think that helps at least give a sense to the reader that this is kind of dynamic developing area. And, some aspects of this could change, but right now, based on what we know, these folks are really, classic examples of what, doctors and people who are studying this, people who are on the ground, like Dr. Putrino, are seeing and saying, there's no other explanation for this. And I'm seeing, dozens or hundreds of people who present exactly the same way. So I guess that is a way that I try to navigate that.
And we're also seeing a lot of uncertainty around just the medical studies too. I mean, beyond long COVID, we're seeing, we have these preprints that don't go through the regular vetting process. And as Dr. Putrino just described, a situation where researchers, even when a study is being vetted, are asking questions that don't reflect our latest understanding or a complex understanding of how things might be playing out in communities. So how do you navigate that, and what cautions would you have for reporters when they're doing, say, a daily on a big study?
Yeah. Well, um, make sure you understand what the study has found and how it's set up and how it was conducted. And, and if you don't have independently, all the skill sets to figure that out, have trusted experts who can help you walk you through it. Make sure you know the limit. Every study is going to have some limitation. Make sure you know what those are, and figure out, weigh that and say, okay, well, did the limitations in this case kind of outweigh, the power of these findings? If it's a very small study, for example, if it's a real outlier, if it's sort of like good scholarship that you've been following in this area has kind of fairly consistently hovered around a certain consensus understanding of this condition, and then comes this one and it says, no, actually it's, caused by X, and we know that because we did one kind of laboratory experiment with an organoid, then, you need to kind of, I would often kind of say, let's just wait on that. Let's not give it the platform until we see those types of results replicated with different types of, real world experiments, actual patients, that kind of thing. So this is good advice for any study reporting that you're doing, but I think especially in this pandemic, where the wonderful thing is that people are kicking out research like crazy, but it's also can get very confusing and can get overwhelming, and some of it, as you said, has not been vetted, and so you just have to kind of put a lot of different safeguards on, and run every study through those safeguards that you have established with the help of your experience or with the help of experts. And it's have the courage to go against the grain in terms of the media world. There was a study, this is not a long COVID study, but this was, I think, in maybe May or June, that was in, I think, one of the JAMA journals, maybe JAMA, that was getting a lot of press, like on deadline from our major competitors and others, saying that something, I can't remember the percentages now, but some huge percentage of patients on ventilators were dying. And my editor said, well, we have to do this. What about this? And I sort of looked at it and I was like, you know what? That study, if you look at what they did, they didn't take into account all the people who were still on ventilators, right? So there were, whatever it was, 20% of their patients who were on ventilators were either they'd gotten off and they went home, or they died. But the 80% were still on ventilators, and we didn't know what was going to happen to them. So it was hugely irresponsible to write a story saying 80% or some whatever 60% of people on ventilators die. That just wasn't the case. So I pointed that out, and actually, I was felt a little bit vindicated a day or two later because the journal ran a clarification, they ran a correction saying, we shouldn't have presented it this way. That doesn't always happen, but you have to have the courage to say, look, I've looked at this and I've talked to a couple experts just to check my instincts and check my thoughts about it. And they're warning us away from this. And they're saying, wait, or it doesn't quite fit, or there's something doesn't wrong with it. You have to have the courage to do that. And I know that's not always easy, but sometimes that's important too.
Yeah, thank you. That's really valuable advice. Dr. Putrino, I'm going to turn back to you. Even though all this sounds really scary, you've had some positive early results in your treatment approaches. And what are you seeing, and what are others seeing, and what is working to treat these patients with these baffling combinations of symptoms? And what kind of research are you doing to evaluate the effectiveness of the interventions?
Yeah, it's a great question. So to build off of what Pam was saying, I think I want to preface this by saying never trust a scientist that says that they've got it all worked out, and never trust a scientist that tells you that their approach is the only approach, because those are surefire signs that they're probably selling something. And as I've been saying for a while, we're probably looking at many syndromes, not just one syndrome, but you'll notice in the media, there's lots of people trying to sell lots of different things. They're saying it's mast cell activation syndrome, it's ME/CFS, it's HOTS dysautonomia, it's all of these different autoimmune conditions are coming out of the woodwork, and these are all fine theories. But we need to remember that these are all syndromes, which are diagnosed typically by checking off symptoms on a checklist. And so, you can technically check off all the diagnostic criteria easily, but not really have the syndrome that is you're being told that you have. So we've tried to be very syndrome agnostic. And so, I think the most confident that we were willing to go for as we were starting to get our head around our patients with post-acute COVID syndrome was that many of the symptoms reminded us of dysautonomia. They were dysautonomia-like. So dysautonomia is this condition where the autonomic nervous system starts to get knocked out of balance. And the autonomic nervous system is this part of your nervous system that controls all the things you don't need to think about. So when your heart should beat, when you should breathe in, when you should breathe out, when your digestion should start and stop, all of these things that you don't usually need to focus on or think about, that your body just miraculously does, suddenly it's having a hard time knowing when to do it and knowing what to do correctly. So we started to go down this dysautonomia rabbit hole of, okay, this could be a post-viral syndrome that, because of the intense the intense inflammatory effect of the virus, we've knocked our autonomic nervous system out of balance, and now we need to re-acclimatize the autonomic nervous system to get it back to normal. And so the first thing that we do with autonomic reconditioning is we start to help patients tease out what their triggers are, and typically the triggers are pretty straightforward. It's anything that will raise your heart rate or put you into a situation where your body is switching between different autonomic states that will be a surefire trigger. So eating a massive meal and stretching your stomach out will put you from, I'm really hungry, fight, flight, to I really want to lay down and digest this meal, rest and digest. So many people feel really terrible after eating a meal that stretches out their stomach. So educating, okay, that's a trigger. Hot showers will be a big trigger because the heat and the humidity will rapidly bring your heart rate up, and that's enough to trigger an attack of symptoms. So what do we do? Okay, when you're having your morning shower, get in when the water's a little bit tepid, and then slowly turn the heat up so that you're not going from cold to immediately hot and humid. So educating people on finding all of these little triggers in their life that bring out symptoms, and then managing those triggers have been really influential in getting people to a phase where I feel like I'm in control of my body. So even though they're still having unpredictable symptoms, when they happen, they can usually trace back to, okay, I think I know what's going on here, and I know how to manage. The next thing that we start with is breath work. So one of the most consistent things that we've seen across the board in PAX patients so far is that almost all of them are hypocapnic, meaning low CO2 levels. And we think that is because their baseline breathing rate has increased, so they're blowing off a lot more CO2. And so we enlisted a team of certified breathwork coaches who we typically, in non-COVID times, we have them working with our high performance athletes, and they just sort of amazing team of guys. They just jumped into the fire and started seeing thousands of COVID patients for us. But they developed a breathwork protocol that encourages patients to retain more CO2 and become comfortable with that, so increase their CO2 tolerance. Once we started doing that with patients, we started seeing immediate improvements in symptoms. Now, they still weren't feeling great, but they were feeling more in control of their symptoms, and they also had something to do when they were having symptoms flaring up. Then we started what we called a autonomic reconditioning protocol. Now, this is effectively a graded exercise program, and we based it off of existing dysautonomia literature. There's a lot of publications on reconditioning protocols of this sort. However, because patients were so debilitated, we actually had to make our own program that started way at a lower level. So people are basically, they start by laying on their back and slowly sliding their heels up to their butt and sliding their legs back out. It's like the slowest, most agonizing level of rehab you can imagine. And we have to train all of the physical therapists. We've in-serviced around 600 or 700 physical therapists across the country at this point. We have to train them. This is not your regular PT. You don't push for one more repetition. You strictly follow the guidelines, because otherwise, if you push too hard, they're out for 2 days. Now, we're just at a point now where we've been looking over our data, and we're seeing that we can produce significant improvements in a number of different outcome measures we're capturing, but most notably in fatigue levels, which is really encouraging to see, because that's one of the most debilitating and widely experienced symptoms. And what we're seeing is we're moving the dial around 30 to 40% in patients. But that's the good news. The bad news is after about 150 days of treatment on average. So what does this tell us? This tells us that the protocol we designed is working, but it's working incredibly slowly. So what we're really looking at is 12 months plus of full rehabilitation time for a number of these individuals, which is a really troubling statistic.
We're going to turn shortly to the questions of our audience. We have a number of them already, but I wanted to ask both of you before we do open it up, what sorts, and especially you, Pam, what sorts of story ideas you're thinking about when you hear Dr. Putrino talk about both, like this very complex, very subtle kind of treatment approach, and how that's going to match with the way that our healthcare system works, or how things are going to work with employment for people. I know you have a lot of ideas. Maybe you could start us out on that, and then Dr. Putrino can weigh in, and then we'll open it up to our audience.
Yeah, well, I think the sort of big thought is that, this is a condition just much like the pandemic itself, that much like, acute COVID itself, this post-COVID is going to intersect with every aspect of American life. So, the economy, our lifestyle, our healthcare, everything. So a lot of the questions that I, have kind of, on my list to follow, one of them is what works. And, I'm very interested to hear about Dr. Putrino's program. And, so we'll be looking at, and I know of some other clinics that are, doing some other things. And so that's going to be kind of something to follow. What works and how long does it take and what does it involve and who, is going to be able to follow that. Are there medications that are going to work? All that sort of stuff. And then, questions of, many of the patients that I've talked to, particularly with these sort of cognitive and neurological effects, are, people who were highly functional and had, full-time jobs, nurses, lawyers, people in the financial sector, who are unable to do their job at their full potential, an operating room nurse who can't remember what a scalpel is called and says, give me that thing we cut with, and a lawyer who felt like her brain had turned to white static and couldn't recognize her own car in her own apartment complex's parking lot, and found it just too difficult to return emails and was basically kind of, essentially forced to take a leave. And she was qualified for some disability, but was worried, this is a young woman in her 30s, I think, worried about like, well, what happens next? If I don't rebound, do I have to get, state disability benefits? And that's going to be sort of a major thing, and that a lot of that is going to depend on how the medical establishment defines and recognizes and kind of endorses this as a real condition. Same thing, that's going to have implications for insurance coverage as well. So though, these are just a lot of things that fall under those umbrellas are things that I'm going to be interested in.
Thank you. Thank you. Did you want to add anything before we open it up to our audience?
I think that was a great summary. I totally agree. I mean, I think stories we need to, the narrative we need to start pushing is what's next? How are we going to look after these people who have been damaged by the virus? The next question is the other thing I want to talk about is, avoiding tons of media around miracle cures. All of these other communities that I've spoken about for a long time, MECFS, mast cell activation syndrome, and POTS dysautonomia, there are no miracle cures. There's no magic bullet. There's no, it is always about management of lifestyle, symptom-centric care, and finding regimens that work for you specifically. And that's the expectation we need to set, because as someone who is already fairly overworked, I've got to tell you, every time a miracle cure story comes out, my inbox gets full of patients who tried the miracle cure and got massively let down. So please don't do that to me. It would be my ask of everyone assembled here.
Thank you. So we have a question from Wendy Carroll, who says, is it true that long haulers who've had one COVID vaccine start to feel better with most symptoms dissolving? Speaking of your comment, and many think that that this is a possible answer or way to look at reversing this challenge.
Okay, so vaccines and long COVID. Let's dig in. There is certainly a reason to think why that would make sense that there is an immune link to long COVID, and why vaccines might influence one way or another symptoms. Everybody's data so far that I've reviewed says the same thing, which is around a third of people feel better, around a third of people feel the same, and around a third of people feel worse. So that is not to say that there is not a legitimate effect of the vaccine on COVID symptoms, and that it may give us a clue that what we're looking at is something that is immune mediated. But what I will say is no one's doing the study that needs to be done, which is a placebo-controlled trial, where a bunch of people with long COVID get a saline injection and a bunch of people with long COVID get the real vaccine. That is the only way we will actually be able to get through the truth of all of this. Because, you know, when we think about the placebo effect, well, there is nothing more placebo-esque than here's a giant needle that I'm about to stick into your arm. And your whole life has been swirling around about, will this make me better or will this make me worse? You know, it's so, in a situation like that, it's so hard to rely on self-report. And it's a challenge. So although there are many good justifications for why it may be the case that the vaccine is helping or harming, we just can't know without a good placebo-controlled trial.
And I guess I'd like to sort of tackle that in a journalistic way. So I wrote a story about this question, and I did a few things that I actually haven't seen in any other coverage of this. And it took me a couple days longer to get the story done because of this, but it was, I think, really important. One of the things that I did was because, as Dr. Putrino says, you know, the data, which at this point it's survey data, right? Which is one kind of data, and it's interesting. A lot of it comes from people who are joining networks of COVID survivors, but there are built-in limitations to that as well, so you have to recognize that. And you know, and I've also talked to a couple of doctors who are saying that they're hearing from their patients, say 40% are saying that they feel better, but some segment, I don't think it's been as high as a third in what I've seen, but maybe 15%, 20% also feel worse, and a whole lot of people don't feel any different. And so I felt like it was really important to not only talk to people who said they were feeling better, but also represent the voices of people who said they were feeling worse. And so I included somebody like that. Also, in terms of the people who were feeling better, this kind of gets to one of your questions, Michelle, earlier, which is kind of how do you evaluate? Well, yes, this is all anecdotal and it's hard to evaluate, but I included the voices of people in my story who were not the people who went in, you know, thinking, at least according to their stories, which were very credible to me, they didn't go in there saying, I'm going to get a vaccine, I wonder what the effect is going to be. These were people who'd already had the vaccine, and in some cases felt a lot worse initially. You know, for a few days, they had the usual vaccine side effects. And in their case, because they were suffering from long COVID, it was really bad for them. And one of them told me that she didn't even, you know, she had to actually be talked into getting the second dose. So this was not somebody who, you know, expected that the vaccine would help her. And then she was sort of stunned, you know, like she happened to be a theater person. And she said, you know, I've been dealing with this for 8 months and I felt terrible after my first dose. And I actually felt really bad after my second dose. But a few days later, it was like, all of a sudden I'd been directing Sweeney Todd and I woke up and I was like directing Oklahoma. It was like, oh, what a beautiful morning. And, you know, those were the voices that I sort of highlighted because to me, they seemed very credible in that they did not have the expectation. And then the other thing that I did is that Dr. Putrino is absolutely right that like the sort of gold standard study here would be comparing against people who are getting a placebo vaccine, but there are, you know, ethical and societal reasons why we don't want to do that. But there are also people who are trying to study it in a little bit more of an indirect way. So there's one, you know, really prominent scientist who's going to be, or starting actually, looking at kind of physiological indicators of people before they get vaccinated who have long COVID and after. So it's one thing to say, you know, my brain fog cleared, but it's another thing as or it can be an additional thing if you had a racing heart rate before you got the vaccine, and then a month later, that's normal, then maybe the vaccine for you is doing something physiological as well. But, in all of this, you sort of have to say, this goes to the complexity of this thing. For some people, it might help. Apparently, for other people, it's not. It's definitely not a cure. It's definitely not going to help everybody, at least it appears, right?
And I think you just made a really important point, Pam, because this idea that you wanted to find patients for your story that represented the complexity and the array of responses, or in other instances, it might be the array of different profiles that emerge from the research, because otherwise we're really talking about, well, what are the first 3 people who replied to my email? And that's tempting on deadline, especially if somebody has a dramatic story, but it's not really doing a good public service. So,
Right. You have to, and believe me, I know that you can, there are things that are tempting to include, but you just always, I mean, in any kind of journalism, you have to be willing to walk away from something that just doesn't smell right, doesn't have all the, all the sort of evidence underneath it that, again, this is an area where we're not going to be able to have every I dotted, but you have to say, we want a lot of the I's dotted as much as we can. And then we want to fess up with the reader and say, these other I's out here, nobody knows how to dot yet. It's a really bad metaphor, but, but you know what I mean? Just sort of like set high standards, try to, for your own reporting, try to stick to them as much as possible, and come clean about what you or the world of science isn't able to find out yet.
thank you. We have a question from Tina Say, who says, Dr. Putrino, are you beginning to see clusters of symptoms together that would suggest different syndromes with a common mechanism at work?
It's a great question. We don't yet have enough data for me to credibly say that we're seeing different clusters of symptoms. One of the biggest issues in our data set right now, looking at around 800 or 900 patients that have come through our clinic and looked at our and very kindly filled out our massive symptom tracking questionnaire, is that the most prominent symptoms, so cognitive difficulties, shortness of breath, fatigue, exercise intolerance, chest pain, it's like 80% of the population or over are reporting that. And then things drop down to sort of like 40% of the population, and then it's like a big mess of symptoms that, somewhere in the neighborhood of 10 to 40% of the whole population are reporting 60, 70 different distinct but different symptoms. And when symptoms are so diffuse and diverse like that, unfortunately, it creates more and more, it creates a greater need for more and more data before you can start to cluster it out statistically to any level of significance. So right now, we're not seeing any clear clustering. I'm not particularly convinced just yet on any other groups who have been clustering out their data, because they're using samples of like 125 patients, and you can create noise in those sorts of samples really easily that look like clusters, but they're not. So right now, not so much. We are definitely, what I can say is, in terms of response to intervention, there's high diversity in response to intervention, which usually tells us that there's more than one group in what we're applying the same intervention to. So although, as I said earlier, we're seeing some encouraging results in people responding to our treatments, some people aren't responding at all. Some people are getting way better. Most people are getting moderately better. And what that typically will tell us is that there's probably more than one condition there and we're not being targeted enough. So I think that there's more than one condition, but we haven't seen solid evidence of it just yet. And we're also hoping that some of our immunological studies will shed some light on this as well.
Sorry about that. We have a question from Sheila Dawkins who asks, Dr. Putrino, how do people and kids access these treatment protocols when they are in healthcare deserts and in financial distress?
It's a challenge. I mean, I feel really fortunate that my team is just awesome. So typically what we do is anyone who's struggling to find someone who's clued in on long COVID, basically what we say is we want an echocardiogram to clear your heart. That's the one thing we worry about, because all of these symptoms, chest pain, fatigue, exercise intolerance, can easily be pericarditis, myocarditis. It happens like 1% of the time, but 1% of the time is a lot when you're starting to deal with the numbers that we're talking about. So as soon as they're cleared from a cardiac point of view for gentle exercise, at that point, if they can't find a PT in their area, we will find a PT in their area and we'll in-service the PT in their area. So that's kind of how we've been doing it. And we kind of do it haphazardly in terms of just like whoever we've been trying to upskill and also just align with a lot of the other major health systems around the country, and share notes as much as possible. You know, we've got like a Dropbox full of resources that we just sort of like share between all of us. So that's been the one thing. Then on the other hand, when we find someone who is out of options, we just treat them pro bono, and just, you know, I guess it's the Australian in me coming out. We just give them free healthcare because that's kind of the culture that we're used to. So we try to work with insurance, but if insurance isn't going to pay, we just say, look, we'll look after you, because once in a 100-year pandemic, we got to look after our people.
Dr. Putrino, that's very inspiring, but it seems like there's only so much, you know, one clinic can do, which leads me to another question from somebody here, Jean Pinder, who says, we've been reporting a lot on long COVID at clear health costs. We're increasingly convinced that this is a giant, slow-rolling public health crisis that will affect millions worldwide, some for years and maybe for the rest of their lives. Is that alarmist or real? And if it's real, when will the appropriate amount of credibility and resources be devoted to this, and what will cause it to change?
Yeah, this is a struggle for us. We're really concerned about, you know, as Pam was saying, that our data suggests that 60% of people have had a change in employment status. You know, this is, and if this goes untreated, and if it is something similar to what we think it is, such as a dysautonomia-like condition, what we know is that if it goes untreated, it will just get worse and worse over time, and people's worlds will get smaller and smaller. And so we are looking at a looming health crisis if we don't act quickly. I think that NIH, CDC, and SSA are doing a wonderful job within the resources that they have, and, you know, just the level of, you know, they go from dealing with an acute COVID crisis, inheriting a COVID crisis where there was a lot of mismanagement that made numbers much, much worse, moving into a push for a logistics push around vaccination. And now finally they're getting to turn their attention to long COVID, and they're doing their best. I hope that us all being very community minded and being collectivist rather than individualistic to meet this challenge. So, you know, I've been somewhat inspired by the fact that, you know, many of our biggest, you know, rivals in terms of health systems, we're just sharing information, and we're just, you know, and we're sharing patients, and oh, you've got a space, go take this patient, and and just trying to work it out, because I think we all understand what's coming if we don't take that approach. But yeah, we are concerned. One of the grants that we're applying for at the NIH is really focused on trying to build our program into an unsupervised program, so that we can dramatically cut healthcare costs associated with providing a program that clearly seems to be working, but is high intensity and requires a lot of synchronous monitoring from a physical therapist. So if we can use a combination of novel technologies and really great training on the physical therapy side to make it so that you only need a physical therapy appointment once a week or once every 2 weeks, and for the rest of it you follow instructions on an app and use biometrics to make sure you're staying within the right exercise bounds, that would be really encouraging, and that would dramatically reduce the burden on the healthcare system if we can make that happen. But it's at front of mind. It is a concern. I'm not going to say that it's not.
And we have many more questions. Do you two have maybe another couple minutes to tackle a few more? And then two questions that I'll read. They're kind of related. And so forgive me if I overburden you here, Dr. Putrino, with a lot of nuance here, but I thought they were similar. One from Marissa Oliver, who says, how do you explain the psychological effects of the virus? I'm not referring to the emotional fallout as the result of the trauma that a patient may have undergone, but how a long COVID patient's brain may be changed and thus their personality impacted by the virus, causing depression and high levels of anxiety or other emotional states that weren't there prior to contracting the virus. And then Juliana Jimenez says, how do we know about the effect of the virus in the brain and triggering depression and or anxiety? Aside from the emotional trauma of contracting the disease, is there something specific happening neurochemically that can trigger these diseases?
I think that these are great questions. These are, as a scientist, these are really hard questions to answer, because we hate lots of variables is the bottom line. And so both people who asked great questions both said, apart from the massive trauma, right? Well, yeah, apart from the massive trauma, apart from the being at home, being passively treated for COVID, thinking maybe you're going to die, apart from the social isolation associated with being at home and not being around, apart from loved ones dying, et cetera, these are all things that we can't fully discount as being causative agents of anxiety and depression in our long haulers. The fact that suddenly you have to deal with the fact that you have a chronic illness, suddenly your entire body is telling you, even though you used to run marathons, your entire body is telling you you can't even get out of bed and walk to the door to answer the doorbell, and no one is telling you that that's going to go away. Some of the dysautonomia like symptoms, just take a moment to imagine, if you have not had people who have experience in behavioral management of these conditions explaining to you why, when you step into the shower for your morning shower, one every 5 showers you go into an intense spiral that makes you think that you're going to pass out in the shower, and you have this feeling that you have no control over your body. These things would cause anxiety disorders in anybody, because you've gone from having complete mastery over your body to having no control whatsoever. So these are all challenging factors to try and tease out. Now, the available literature, the general consensus on the neurological literature around COVID-19 entering the brain is that from cadaver studies, it's rare. So the idea that COVID is in the brain and is affecting neurochemical balances and causing anxiety and depression where previously anxiety and depression didn't exist. We can't rule it out completely, but we can say from the available literature, it's a less likely scenario. But we have a lot to learn. So, you know, the problem is it's such a messy space that we're dealing with right now, and we all know that the body affects the mind and the mind affects the body, and dysautonomia is really one of the, you know, best examples of that, actually, of what a profound effect the mind can have on the body and the body can have on the mind. So right now it's just too early to tell. That's my long-winded way of saying I don't know. But yeah.
And if I can just add one thing to that, all which I agree with, but just to sort of clarify, you know, it's absolutely true that that there's been very, very little evidence that the virus invades the brain. May be able to happen on isolated occasions, but in contrast to, say, a virus like Zika, which we know attacks, you know, developing brain cells in the fetus, this is not the way this virus works in any, you know, large scale way. But there still could be like a physiological or several different physiological mechanisms that aren't just related to all of the things that, you know, all of the trauma that you'd be experiencing. And I think, you know, the folks, the scientists that I talk to a lot are looking at, you know, how does this immune system activation that people with long COVID appear to have, something about their immune system didn't shut off or is still fighting maybe a DNA fragment that's hanging around from the virus, or maybe even a little bit of, you know, a reservoir of virus that can cause effects not only on the body, but, you know, or the other parts of the body, but also on the brain. It can potentially cause, you know, inflammation to inflame blood vessels that also could be inflaming blood vessels in the brain, right? And could be causing symptoms that way, or the release of neurotoxins that might be able to cross the blood-brain barrier that could be causing symptoms that way. So I think those are some areas, especially the inflammatory response. That seems to be something that people are, you know, are looking at. And there've been some brain autopsy studies that have found, you know, no virus in the brain, but these blood vessels do seem to be affected, you know, in the brain tissue that they've looked at. So that might end up being a likely pathway of what's happening here, right?
Absolutely. I mean, this neuroimmune story is really it's compelling, and it's just, yeah, we still need better pathophysiology to, you know, to understand what's going on, because there's not a, in my, you know, somewhat novice opinion on neuroimmune stuff, I will admit to being not always the full bottle on these things, but there's not a clear jump from a neuroimmune component to specifically causing anxiety or specifically causing depression. Now, that's the, you know, that's the piece of the puzzle that we need to work out, if it's happening. And there are some phenomenal immunologists that, you know, I'm chatting with who are looking into this sort of thing. But yeah, lots of research to go before we get to it.
And as one neurologist that I spoke with, you know, sort of said, you know, there's not a whole lot of real estate in the brain, right? And there's a lot of overlapping functions. So if some small area is inflamed, it may play a role in, you know, a number of different functions. It could play a role in executive function. It could in memory, you know, in some emotional aspects as well. So, it's complicated. It's complicated.
Absolutely.
And we're gonna close with a final question for you, Pam, on reporting strategies, because we've just talked about so many different conditions that are associated with this, and there may be people who, had a mental health condition before, or chronic fatigue syndrome before. How do you sort that out as a reporter to figure out what you're hearing from people? Um, what part of that is COVID and what part of that is their health beforehand, and just how do you navigate that? Because as soon as you profile somebody, you're legitimizing something.
Yeah, and I think that, that's sort of a similar answer to what I gave before, just trying to, get a sense of their medical records, talk to their physicians, ask the questions. I have to say, I've talked to a lot of people who are going through this, and I have found them to be incredibly earnest and and credible. I mean, they answer questions like, did you have this issue before? They will answer that, and then I may say, oh, well, in that case, in this particular story, that's not what I'm writing about, so your particular experience doesn't fit this story, but that doesn't mean it might not fit a different story that I will be working on later. That's going to be a really important question down the line, which is, what pre-existing conditions may or may not make somebody more likely to have certain symptoms. That's a whole nother area that we don't know about. But, so I guess, it's just kind of asking a lot of questions and trying to cross-check with different things and using your sort of credibility meter. But it's an honor to talk to these patients, honestly. They have been very generous and often very courageous in sharing things that particularly some of these cognitive issues that can be very stigmatizing. And so I always sort of, take that as a frame of mind also, and just try to deal very respectfully with whatever it is that they are sharing. And even if it's not appropriate for a particular thing I'm working on, letting them know that, and that, that doesn't mean that what they're experiencing isn't important and may not be relevant to some other thing down the line. That help answer the question.
No, thank you. That's very insightful and really helpful as we all think about this. Well, with that, we're going to conclude this webinar. I would like to thank our wonderful panelists, and I would like to thank our audience for their questions. We're sorry that we weren't able to answer all of your questions, but we do have a regular column called You Asked, We Answered, and we'll try to get to some of them there. Should you want to support us in hosting these webinars, please feel free to just send a text to 41444. Feel like a salesman, and type the message CHJ for further instructions. We'll be sending you a survey a little later, and to ask you about this program and also your ideas for future ones. And the webinar will be archived on centerforhealthjournalism.org a little later today. Thank you so much, and have a good and healthy day.